Good morning. This is now our one of the primary plenary sessions for the International Coronary Congress each year is to grant a Lifetime Achievement Award or awards and to have keynote lectures. It's an especially significant event this year because I think, as you'll see, we have some really distinguished honorees, people who have made immense contributions to the field of cardiovascular care and to the care of the coronary patient in particular. Before Dr. Taggart acknowledges our first Lifetime Achievement Award winner, I'd like to remind all of you that we have lunch symposia beginning at noon, and in the afternoon we once again have 2 sessions in the Training Academy. I would encourage all of you to please go to the Training Academy, which is down this end of the corridor, and take home with you some hands-on experience that you might not otherwise have had. And now Dr. Taggart, my partner in crime, will announce our first Lifetime Achievement Award winner, 2023.
Thank you, John. Could I have my slides, please? Great. So it's an enormous pleasure and privilege this morning to acknowledge 2 of the greatest innovators in coronary artery revascularization that we've ever had. We've got one of these innovators today with us, Dr. Patrick Serruys, whom John Puskas is going to give an acknowledgement to. But I, in the meantime, am going to acknowledge Professor Frederick Moore. The slide's going back, okay.
Back one, back one.
That's a bit annoying, actually, but anyway. Can you go to the first slide, please? Yeah. Thank you. So, Professor Frederick Moore was born in 1951. And when you say, and I say, he's a very real giant of cardiac surgery, I can say this with some authority, because I worked for Professor Sir Magdi Yacoob, who is also a true giant. And if you look at what Professor Moore did, as I said, born in 1951, educated in Bonn, Sydney, Berlin, and Cedars-Sinai, where he did his research. He was the director of the Leipzig Heart Center, biggest center in Europe for over 20 years. And it's astonishing that he educated 50% of the chiefs of surgery in Germany. Almost unparalleled, unheard of. He published over 900 scientific publications. If you look at his innovations, I could go on for half an hour, but I don't have time to do that today. So I'm going to point out some of the highlights of what he did. He had numerous innovations in robotic mitral valve surgery, initially with Professor Alain Carpentier. He made major contributions to aortic surgery. He made major contributions to transplant surgery and major innovations in minimally invasive and robotic cardiac surgery. He was and received numerous German and European awards. It's too long to go into them all, but he received the Federal Cross of Merit of Germany in 2010 in Germany, and that's the highest civilian award in Germany. He was president of EACTS 2015 to 2016, and I'm going to discuss with you briefly what he did with Professor Patrick Serruys, the enormously important contribution of the syntax trial to our understanding of coronary artery surgery. Sorry, this seems to be going backwards.
Tell me next slide.
Yeah, okay, well, yeah. So what I want to address is this paper published in 2013 in The Lancet, Coronary Artery Bypass Graft Surgery versus Percutaneous Coronary Intervention in patients with 3-vessel disease and left main coronary disease, the 5-year follow-up of the randomized syntax trial. And why this is important, I would argue with you or persuade you today this is the most important trial ever published of PCI versus CABG surgery. Published in 2013, but 10 years later is the most relevant piece of evidence we have. And as John explained this morning, even if you look at FAME3, when they tried to use FFR in the most recent drug-eluting stent, coronary surgery remained the best therapy for patients. Sorry, this is going backwards.
There we go.
Are you hitting? There's 2 buttons there.
Yeah, well, I'm hitting the one going forward, but it keeps going back.
Then hit the other one.
Could you please go back? Thank you. So why is this trial important? I would argue it's the most definitive, and I use in inverted commas, all-comer trial of PCI versus CABG in multivessel coronary artery disease. 1,800 patients with 3-vessel disease, plus or minus left main disease. Enrollment between 2005 and 2007. And what was crucial about this trial, and I will show you why, it also had a parallel nested registry, because every single previous trial of PCI versus CABG were extremely exclusive. The syntax trial did its best to really try and represent real clinical practice. Now, while it's popularly said that it invented the concept of the heart team, it didn't actually. The heart team concept had been expressed before this, but certainly syntax popularized the concept of the heart team. And what it also did was it indicated to us what is the optimal treatment of patients with coronary artery disease who need revascularization. Now, why was syntax so important? This is a paper I published in 2006, so 7 years before, in the Annals of Thoracic Surgery. And at that time, I went through the 19 trials of PCI versus CABG. And what I pointed out was that although they included almost 9,000 patients, they only enrolled 5% of the potentially eligible population. So they excluded 95% of patients. But despite that, what did happen then? Well, these trials were then used, despite having patients with very low severity coronary artery disease. It told us the patients in the trials were very different from what we did in routine clinical practice. But what was the outcome? These trials were then used to generalize the results of this very highly selected population to all patients with coronary artery disease. So they took a very highly selected population and then manipulated it as if it was a general population. And worse than that, these trials were then used to underpin guideline recommendations for PCI versus CABG for the whole population. So they were a complete distortion of real medical practice. So if we go back to the syntax trial at 5 years, I would argue, as I've said with you, this is the most important study ever published concerning PCI and CABG. And what it showed us was in a randomized trial of patients with relatively real clinical coronary artery disease, that cardiac surgery significantly reduced the risk of death, myocardial infarction, the risk of composite endpoints, and the risk of the repeat revascularization, and with no difference in the incidence of stroke. But even more importantly, and this is a paper from Dr. Moore and Dr. Sorois, what this showed us was the importance of estimating the severity of coronary artery disease. So if you look at patients with scores, syntax scores below 23, we can see that there was only 1% difference in death rates between CABG and PCI. But if we go to the intermediate group, patients with scores of 23 to 32, these are young risk patients with relatively low severity coronary artery disease, an absolute difference in 7% and 7% in the risk of death at 5 years. And if we look at the patients with the higher scores, syntax scores above 32, we see an almost 10% instance in difference in death. And these are young patients. So these are patients who should have a life expectancy of 15, 20 years. And even at 10 years, we see a 10% difference in the risk of death. This is the most important data we've ever had comparing PCI and CABG. So what has the effect of the syntax trial been worldwide? The evidence is crystal clear. But what has it done to clinical practice? If you're in my country, the UK, for elective patients, and let me stress this is not patients with acute coronary syndromes, this is elective patients, the risk of PCI, or the ratio of PCI to CABG is 4:1. If you go to Europe, France, Germany, Italy, Spain, it's 10 to 15:1. If you go to the United States, 12 to 15:1. And if you go to Asia, 25 to 30:1. So here's my big question today. Who in the audience can explain these figures to me? Dr. Sarois?
I know the number.
But can you explain the difference?
No, I think it's a basic mistake. If you take the syntax trial,
Please, thank you.
if you take the syntax trial at 10 years, vital status, in the randomized and in the registry, I can tell you only 17% of the PCI procedure would be justified. So the opposite
Only
of
15%.
17% would be justified.
Yeah.
The rest should have gone to surgery.
So it's great.
That paper has not yet been published. Is rejected by a lot of people. I don't mind. At some point I will have it. But it's amazing that the people cannot accept that reality.
So it's great. If I don't have the slide today, but if you look at the great Andreas Grunzig, the father of interventional cardiology, he wrote in the New England Journal in 1986, only 10 to 15% of patients with coronary artery disease are suitable for PCI. But look at these ratios. How do we explain this? And the person who explained it was Shakespeare. You might think, how could Shakespeare explain this? Because he was born a long time ago. And what he said was, in his greatest play, arguably his greatest play, Hamlet, Prince Hamlet said, there is something rotten in the state of Denmark. And I would say today that you could change this to say, there is something rotten in the state of medicine. You cannot have a country like the UK, where every patient who requires intervention is decided by a heart team. No patient gets intervention where it's not agreed by the heart team. But if you look at what's happening in Europe, the USA, and Asia, there's something rotten in what we're doing in medicine.
Went from A to B.
And my view here today is, as it's been for many years now, is no patient should have an intervention unless it's agreed and approved by the heart team. And I think that's absolutely mandatory to protect the interests of patients. So I believe today that any intervention done on a patient which has not been agreed by a cohort of doctors who are experts should be an invalid, unethical procedure. On that point, I'm going to conclude my talk. I would like to thank the organization for the invitation to be here today again, and for you, the audience, for your attention. Thank you.
Thank you, David. We have a Tiffany's blue bag for Dr. Moore, which will be couriered to him. He was not well enough to join us today, unfortunately. Recently released from hospital, been recovering. But we wish him well, and we are very, very grateful for his leadership for these many decades, and especially for his partnership with his interventional cardiology colleagues in leading us forward in a true heart team approach. Could I have the next set of slides, please? So David kind of tipped the hat and showed us who that person might be, but I'm going to start by briefly reviewing those who have previously received Lifetime Achievement Awards. Our inaugural meeting in 2015 recognized Bruce Lytle and Sir Brian Buxton, giants of arterial grafting. Dr. Naresh Trehan, who leads the biggest Indian program for coronary artery surgery, was our 2016 honoree and hosted our meeting in New Delhi. George Green, who we're going to have the privilege of speaking with tomorrow at this time, performed the very first left internal mammary graft to the LED in North America when I was 8 years old. And he'll be back. He is not 8 years old anymore. He's closer to 98 years old, but he will be here with us tomorrow. In 2018, we had the privilege of having our ICC in Fuwai Hospital in Beijing, and Dr. Shengshu Hu organized that, and he still leads the largest coronary program on the planet. In 2019, Dr. Antonio Calafiore was recognized for his many contributions to minimally invasive and coronary surgery. And in 2020, these two giants of early development of off-pump bypass were recognized. You heard from Dr. Sargent earlier today. In 2021, we recognized Tom Salerno for his contributions to coronary surgery in multiple ways, and Dr. Kim from Korea for his careful study of the role of arterial conduits and venous conduits in their application to coronary surgery. Last year, we were in Tokyo and recognized Dr. Sezai, who founded in 1996 the Japanese Association for Coronary Artery Surgery, which predates our international society by more than a decade and a half, and really was an inspiration to us in founding the International Coronary Congress. Dr. Suma, of course, popularized the gastropapua artery. But this year's keynote speaker and honoree for the Lifetime Achievement Award was born in 1947 in Belgium, but interestingly, he grew up in the Congo. I do not have another friend or colleague who has been photographed sitting on a living hippopotamus. So this is just one of the many ways that this gentleman is unique. He learned 6 languages: English, French, Flemish, German, Greek, and Latin. Returned to Belgium to study philosophy and medicine at the University of Leuven, graduating summa cum laude in 1972, and began working in the cath lab in Leuven in 1974. He focused his career at the Erasmus Medical Center in the Netherlands from 1977 to 2014, where he was Chief of Interventional Cardiology at the Thorax Center and Professor of Medicine. He moved to Imperial College of London in 2014, where he continued to serve as Professor of Cardiology in the National Heart-Lung Institute. He became the established Professor of Interventional Medicine and Innovation, which is a theme of his life, innovation, at the National University of Ireland in Galway more recently. Between 1976 and 1982, he established the methodology of quantitative coronary angiography. So QCA is one of his achievements and contributions, and he did this typically in partnership with engineers and experts in other related fields. In 1980, he studied balloon angioplasty and mechanisms of restenosis, again with a multidisciplinary approach, and conducted the first randomized controlled trial of stenting that actually led to the FDA approval of stents. He's the first author of this paper. He introduced the use of drug-eluting stents to the world in 1999 and published the first RCT that demonstrated the benefit of drug-eluting stents in New England Journal in 2002. So just this one slide demonstrates 4 areas of contribution, each of which would be worthy of a career. We recognize him in particular as the father of the Syntax score and of the Syntax trial that David very nicely summarized. It remains perhaps the most impactful study of coronary disease ever conducted. And it reached the conclusion that CABG remains the standard of care for patients with triple vessel or left main disease, since the use of CABG as compared to BCI resulted in lower rates of the combined endpoints of major adverse cardiovascular and cerebrovascular events at 1 year and then again at 5 years, very similar results. You see the two gentlemen that we're recognizing today. This is a true heart team, Professor Dr. Friedrich Moore and Professor Dr. Patrick Washington Sorois, here together in front of their team of people that helped them conduct this trial. But it goes on. Dr. Sorois is also the father of the bioabsorbable coronary stent and published the ABSORB trial. Not everything you dream up works perfectly. And we know bioabsorbable coronary stents have not lived up to the earliest hopes and aspirations, but that's part of innovation. He remains a senior author and European leader of the EXCEL trial, published in the New England Journal in 19. And in both the Syndex trial and EXCEL, he sought to conduct science in a collaborative, multidisciplinary way, and I can personally vouch for that. His partnership with Fred Moore in the Syndex trial and subsequent publications of those outcomes remains a gold standard for intellectual honesty and multidisciplinary collaboration in cardiovascular care worldwide. Dr. Sorois has had countless honors and awards from literally every major cardiovascular society and association in the world. And this last line is really quite remarkable. His H index is really off the charts. He developed the Syntax score to quantitate the complexity of coronary atherosclerosis, allowing the quantitative understanding of fundamental concepts that coronary complexity impacts outcomes after PCI, while non-coronary comorbidities have a greater impact on outcomes after CABG. And this is a basic concept that it took us as a field a surprisingly long time to really absorb and integrate into our thinking. But he was way ahead because he then developed the Syntax 2 2020 score and various algorithms to predict clinical outcomes after either PCI or CABG for a given patient based on coronary and non-coronary risk factors. Really, this is an algorithmic way to help us make the right decision for our patient. And it's interesting how much flack he's received for developing such an impartial, objective, and important decision-making tool. He most recently conceived, designed, and conducted the Fast Track trial, which is a first-in-man trial of the use of coronary CT angiogram and CT FFR rather than invasive coronary angiography to guide the performance of CABG in patients with multivessel disease. I had the privilege of being the only surgeon in North America enrolling patients in this trial, and I can tell you that the conduct of the trial was of the highest order. This groundbreaking trial promises to revolutionize the diagnosis and treatment of patients with coronary artery disease and to create a new multidisciplinary team for that care. AI-powered analysis of the next generation CTA, CT-FFR may well become the new gatekeeper due to his visionary work. So I would like to recognize Dr. Patrick Sorois as a world leader in interventional cardiology since its birth, a relentless innovator, a brilliant scientist, a mentor, a collaborator, and I am proud to say a friend, Dr. Patrick Washington Sorois.
That's great.
You have 45 minutes. I can be on a panel discussion if you went a little early.
All right, I'll do my best. It's a great honor for somebody who said one time, I was young, bypass surgery will disappear. The problem, I don't know when. And unfortunately, the people quote the first part of the sentence, but not the second part. And I think by the time surgery disappears, PCR will have disappeared also. Okay, today I will talk about the CT coronary heart team, a new paradigm. In 2018, we did publish that paper, Coronary Computed Tomography Angiography for Heart Team Decision-Making in Multivessel Coronary Artery Disease. In one word, in presence of left main of three-vessel disease on conventional angiography in 223 patients, all these patients underwent a CTA, and then they were randomized. We randomized the doctors, not the patient this time, and there was the heart team A with sole access to cine angiography, and heart team B with sole access to CCTA. And the primary endpoint was the decision-making and treatment strategy based on the syntax score 2, the father of the syntax 2020, combining anatomic syntax score and comorbidities. And that was the primary endpoint. Now, we achieved a Cohen kappa of 0.82. The statistical term for that is almost perfect. That's the term used by the statistician. In simple words, the concordance between the two decision-making was 92.8%. And the secondary endpoint was the use of the FFRCT, and I discussed that this morning. Now, what we learned in this trial that the FFRCT could change the treatment recommendation in 7% of the patient. The FFRCT changed the vessel to be revascularized in 12% of the patient, and the FFRCT reduced the number of patients with hemodynamically significant pre-vessel from 92 to 79%. Now, after that, we did something funny. We took all the surgeons, Dunst, Morera, Plas, Marc Lamer, and Giulio Pompilio. We isolated in a box, and we showed them the patient, the multi-slice CT scan of the patient that they had operated 2 years before. And sorry, to move this. And in 84% of the case, there was an agreement. What the surgeon discovered during the first trial is that, and they said that many, many times, the multi-slice CT scan is much better than the cine angiography done downtown. And that was true, so he said, if you say so, let's make the trial. And this is the fast-track CABG that John was alluding to. It's a first in man, 114 patients referred to CABG by conventional heart team using invasive coronary angiography, and they all underwent a CCTA and a fractional flow ratio. And then the CCTA was transferred to the core lab, blind to ICA. We did a lot of things, as you could see, and the core lab sent the result back in Europe and in the United States, but to a different heart team, a heart team which is a CCTA planning and operating heart team with a surgeon and a radiologist, of course, blind for the ICA. And they operate 111 patients. Now, if the surgical planning was deemed not feasible, and we will talk about the feasibility, then the surgeon was given access to the ICA and unblinded. That's the feasibility assessment. And then they underwent the bypass surgery with the sole guidance of the multi-slice CT scan. And then 30 days later, there was a CCTA to judge the patency and the topographical adequacy of the position of the anastomosis, and that's the safety assessment. Now, the era of extended reality has started. This is the heart team new style in Galway with hologram. You see, we are around the table of the heart team. The surgeon has the virtual glasses on his head. He sees us, but he sees also the heart, and he's explaining to us what is he going to do. And you could see myself measuring the length of the bypass graft for the surgeon. I see the heart in my spectacles, and I'm here indicating the trajectory of the graft above the conus branch to one of the vessels. The surgeon on his way to the surgical theater has hovering above the palm of his hand the heart, and as well in the surgical theater. Now, what do I see in these goggles? You could see the conus branch, the right ventricular branch. We have the LED here. If I'm bowing my head forward, I can remove some soft tissue, and you could see clearly the two narrowing in the LAD and one calcify. You could see two narrowing in the intermediate, and distally in the obtuse marginal, there are severe narrowing. I can even remove the conus bench or remove more tissue and see what will be the future of this patient. Try to anticipate the progression of the disease. I'll do that in a moment by, again, bowing my head forward, and you will see probably what's going to happen with this patient in the future. Here I remove more, and you could see that it could become a very, very even worse disease. You see, by the way, the calcium at the end of the main stem, which is engaged in the circumflex and in the LAD. So that was what I saw. But every Thursday, and John was part of it, we had the heart team conference, surgeon and radiologist, always with the same template. And this is a patient, 81 years old, a male, CCS class 3, glomerular filtration, ejection fraction, pretty good. Euro score 2, 1.2% mortality at 30 days. Now, already the surgeon liked that kind of pictures. You have a global idea about the distal bed and the calcium, and you could see that this trifurcation here is very severe between the LAD, the intermediate, and the obtuse marginal, the circumflex. But the way we did during this meeting is quite different. This is the right coronary artery. There is 3 small narrowing, you can see them. One is here, is calcified. The second one has a small side branch. The distal bed is quite good, 1.5 millimeter. So 6 point in the syntax score. But this is the complex trifurcation, left main, 3 vessel, left main and the 3 vessel. And you could see that the end of the main stem is severely narrow. There is a problem at the ostium of the circ. There is a serious and long problem in the LAD with calcification. So when we are, and the distal bed is again pretty good, 1.8 millimeter. So when you look at that and you calculate that, you have a score of 46.5. And then you go to the intermediate here and the obtuse marginal, 2 narrowing, and here at the ostium of the obtuse marginal, a problem, calcification. So globally, the total score anatomic syntax is 58. That's forbidden and criminal field for the interventional cardiologist. So on top of that, we have the fractional flow ratio. And you see that you have to treat the LAD, you have to treat this intermediate. You can see here the obtuse marginal. It will not be easy for the surgeon. He will have to go quite distally to bypass this. The right coronary artery has a FFR CT, which is borderline, 0.8, and you see multiple bifurcation in the posterolateral and the PD. So the surgeon didn't know what to do. There was a gradient here of 0.06, which is significant. But then we analyzed the content of this plaque here. And as you could see, lipid-rich, fibrous, eccentric lumen, and some inflammation of the perivascular fat. That's what we do on a regular basis. Now, we can do more than that. On top of the epicardial conductance, that's the FFR CT, you could look at the microvascular resistance, the myocardial perfusion, and the myocardium at risk, and the surgeon liked it very much. This is the conventional FFR CT of our flow, but then they have created a synthetic tree based on the Strahler model of fractal flow to analyze all these small vessels, which are so important. And then there is a model where the downstream coronary circulation is coupled with the myocardium model, and then you have a simulation of the myocardial blood flow, which is on the multi-slide CT scan, very, very similar to the PET examination. And you could see that systematically we have the FFR, that's an LT, that's a disease LAD with a huge territory distally. That's what we are going to give systematically to the surgeon at the time of the heart team. So this is what we provide them. You have the two spots here with the FFRCT below 0.8. This circumflex, obtuse marginal, and posterolateral are ischemic segment. You see the FFR less than 0.80 in the LAD, that's the ischemic segment. You don't have to treat the first diagonal. It's okay, it's all in green. And then you can see what kind of ischemic percentage of ischemia you have in this territory. Posterolateral, small, 7.5, but the circumflex itself and the obtuse marginal, 23.1. The LAD, 21.3 and 19. And of course, the main stem, if the main stem would be diseased, will be 78 point. Now, the second point, when you finish with that, and it was mentioned that in 2020, I recalibrated the syntax score 2 in the syntax 2020 that was published in the Lancet. It was validated in 4 external validation, 4 randomized trials. And then the same year, or 1 year later, with my friend in Japan, we validate in the Credo Kyoto study, and you will see one slide of that. And then last week, of course, we introduced the machine learning in the system with some surprise. So you see in red and blue the combination of the traditional syntax score 2020 and what we have discovered with the machine learning. When we have finished with the image, we take our iPhone, we have an app on the iPhone, and you quickly introduce the anatomic syntax score, the age, the creatinine clearance, the ejection fraction, the left main, the gender, the COPD, the peripheral disease, the diabetes, and the current smoking. And then you get the 10 years mortality. Don't forget that patient is 81. So the 10 years mortality with PCI is 63%, with CABG 43.9. That's an absolute risk difference for that individual of 19.5%. More reasonable for him is to look at the 5 years MACE, 49.5 with PCI, 29.7 with bypass surgery. Now, in the study itself, in the fast track, this slide showed the predicted absolute difference in all-cause mortality between PCI in red and CABG in blue in a ranking order of magnitude. Only 2 patients here, only 2 patients has a lower predicted mortality with PCI. In the fast track, 98% of the patients were appropriately selected for surgery and had a lower predicted mortality with surgery. That's the individual plot of all the patients in the fast track study. Now, this is a small series, but with our friend of Japan, we have looked at 7,000 patients, and it's quite a good prediction. The patient treated in Japan had IVUS and second or even third generation of the drug-eluting stent. So it's very, very solid data, and Valentin Förster liked the paper very much. Now, let's go back to the fast track. Was that feasible to treat patients only on multi-slide CT scan? And as you could see, there was only 1 patient for which the core lab recommended to the surgeon to look at the ICA. And the surgeon said, I don't need it, but we said, please do it. And that's the only patient who was unblinded to the surgery. So the feasibility in this study is 99.1%. It looks a little bit like republic in South America after the election, but that's the way it is. That's the way it is.
Or Russia.
No, nothing personal, yeah? So let's go back to the baseline characteristic. You have the age, the diabetes, 1/3, insulin dependent, small numbers, current smoker, peripheral disease, creatinine clearance, and chronic COPD, and left ventricular ejection fraction in general, okay. You have the different syndrome, I'll pass that. 75% had three-vessel disease and 25% had left main on top of the three-vessel disease. Now we look at the number of major epicardial vessel territory with the CCTA, 4.7%, and with the ICA, 4.1%. What is this concept of major epicardial vessel territory? It is basically in vessel greater than 1.5 and related to what I have shown just a few minutes ago in terms of myocardial resistance and percentage of myocardium at risk. And in this patient, there is no posterolateral. There is no narrowing in the circumflex itself, so this posterolateral is okay. And we have basically 1, 2, 3, 4 major epicardial vessel ischemic. As you could see, the anatomical syntax score derived from the CCTA is 43.6, and with the ICA and with the functional is 41.2. I remind you that the syntax score in the syntax study randomized was 28. It was 38 in the registry.
Yeah.
It's here 44. It's interesting, we discussed that this morning's coronary segment greater than 50%, but with an FFR below 0.8 is the large majority, 92.7%. There was coronary segment with a stenosis of 50%, but an FFR CT above 0.8. And it's interesting, there were 51 of these vessels. In general, the surgeon did not bypass this vessel and keep the graft for something more useful. That's the key point, yeah, to have enough graft material to do that. So this is 30-day post-CABG. The CCTA is repeated to assess the patency rate of the graft. You will see, in this case, it's all the same case, the surgeon put the saphenous vein graft very, very high. And as a matter of fact, a little bit proximal to the narrowing. But the FFRCT increased from 0.8 to 0.88, fine. The Lima was beautiful, and FFRCT went from 0.50 to 0.91. And I told you that the saphenous vein graft on this very distal obtuse marginal was not an easy job, and the FFRCT goes from 0.59 to 0.79. Again, I put my glasses and I do the hologram of post-surgery. You can see the Lima, you can see some of the clips. You see the Lima on top of the saphenous graft going to the obtuse marginal, and you can see that the connection here with the LAD is beautiful. Now, the other point is this saphenous vein graft, I told you, was implanted very, very high, and as a matter of fact, just proximal to this plaque. Okay? So we were moderately happy about that. And what you can do with the multi-slide CT scan post-surgery is you can do a 3D printing. That's something we do also on a very regular basis. And what you see here is the saphenous vein graft attached to the right coronary artery very high. And I asked the surgeon, if you detach the rima from the thoracic wall, here is the bifurcation of the rima. You have probably enough space an extension to reach a more distal point in the right coronary artery. And you could see that the distance there is only 2.3 centimeter. That's where we start to liaise with John on an interesting concept that I'm going to show you now. For John, we are measuring the length of the graft to be harvested at surgery. I must say that you should not blush, but I'm very impressed by the type of surgery that he did. This is not the most complicated thing. This is the cartoon he sent to us. He said, I'm going to put a lima with one connection on the diagonal and another connection on the LAD. But then, on the lima, I'm going to put a radial, and the radial will go to the obtuse marginal. And then I'll take the lima and extend the lima by the radial, going to the PD and the other obtuse marginal. Now, that's something that we could analyze in advance for him. If he's asking me the distance between the diagonal and the obtuse marginal, I can do that. This is just the distance between the lima and the first diagonal. But here is the interesting value, 47.7 millimeter. Now, I'm very pleased by this slide and this email. I don't know if you remember that email. Oh my goodness, this is spectacular work, yeah? So we were very pleased, and we continue to that, and we have now a very large series of these bypass grafts. So the future is maybe CTA analysis with FFRCT, volume rendering. Then during surgery with these wireless spectacles, you could measure the distance. And this is the view of one of your patients, John. We put the lima anastomose to the diagonal and then to the LAD, and then a radial originating from the lima and anastomose to the obtuse marginal. And all that is done off pump. And you could see that we control what we said. Here is the distance before the surgery, D1 to OM, and this is the distance RA to OM after the surgery. Now, I'm telling you a little bit more about the fast track. Is that safe? Is that dangerous? Is that going to become the routine? If you ask me today, as an interventional cardiologist, I will tell you that the diagnostic angiography will disappear. And I'll show you at the very end the new photo counting CT scanner. But let's look a little bit to the result of the primary safety point. 102 patients were controlled at the 30-day CTA.
Yeah, I'll bet.
366 anastomoses were constructed. That's a very good CTA follow-up, 91.9%. Anastomoses were patent in 92.6%, and the anastomoses were occluded in 7.4%. Now, I like the series of Han, which is a CCTA pre-discharge, and he found a patency of 95.3% and occlusion rate of 4.7%. I have to tell you that he excluded 25 patients with symptom of sign of myocardial infarction. I prefer the series of Sousa. CTA was done 5 weeks after the bypass surgery, and you could see that the patency and the occlusion rate is almost identical to our values. Clinical outcome, that's what counts at the end of the day. Cardiovascular death in this small series, 1.8. 95% confidence interval is between 0.2 and 6.4. You have there the STS score and Euroscore 2. Death or stroke, 3.6%. death stroke of myocardial infarction in this complex patient, 7.2. Adjunctive PCI, 2.7, very similar to the series of SIMSEC published this year with angiography within the 30 days, 2.5% of adjunctive PCI. And finally, if you look at death, stroke, MI, or revascularization, MACE, it's 7.2%. The BARC 4 and 5 is 3.6%, and the NACE is 9.9%. I'm finishing by evidence. What are the evidence that if you randomize the patient between conventional angiography and CCTA, you will do something good? Now, that study, supported by the European Union, was randomizing between CT and ICA prior to angiography, prior to PCI, prior to bypass surgery. Great number of patients, 3,500. That's the year and enrollment, 2015, 2019. We have 48 months of follow-up, 26 centers in 16 European countries, basically stable patient, and MACE, or MACE extended, was the primary endpoint and secondary endpoint. MACE extended is MACE plus TIA plus major procedure-related complication. And you could see that in the group with CCTA, that was reduced significantly by 40%. And if you look in the first 48 hours of either coronary angiography or PCI or bypass surgery, the reduction of the major procedure complication was 1.9 with ICA and 0.5 with CT in the first 48 hours. And that's a reduction of 74%. Now, photo counting, and I'm finishing on that, will be another revolution and may really enable the evaluation of calcification and stent segment, many other things. The resolution is now 111 micron. Coronary angiography is 200 micron. I'm going to animate that. It will go quite quickly, but I think you will get the feeling of what you see. This is the cross-section of the vessel. The vessel will rotate. You will see that the calcium is on one side and the other side. So this is what you can see. Calcium is really outside the vessel. I don't need an angiography. This is much better than an angiography. So you can appreciate. I start to see things that I've never seen before, that I even don't know, is the fact that in the calcium, you may have low attenuation, never seen before. You cannot see that with the IVUS, you cannot see that with the OCT. Look at the quality of a total occlusion, no cap. Look at the precision of the cross-section. Look at the stent, we can reconstruct the stent. You see the individual struts, you could see the calcium and why the stent is not fully expanded. So, there are today 100 units of these photon counting scanner. This is the future, you know. When you have seen this image, you don't want to see anything else. So, we are in New York, so I tried to make a press release for New York. And basically, when I try to convince founders to support our trials, I used to flash through their mind this fake press release. 2028, non-invasive CT coronary angiography is replacing invasive coronary angiography to guide the diagnosis and the treatment of coronary artery disease. So that's it. Before concluding, I have to thank all these young people. fully committed to research. I have had the 350 in my life. I have now almost 25 or even more. You could see there are some from Ireland, some Dutch, some from Egypt, some from India, some from China, even a French girl and an Italian guy, and Professor Onuma, which is now Dutch and no longer Japanese, and myself with the Belgian flag. So conclusion, multi-center and intercontinental heart team. We did that with John, integrating anatomy, physiology, and clinical data, taking advantage of machine learning and virtual reality is nowadays feasible and is a new paradigm in the heart team. Planning and performing CABG with the sole knowledge of the CCTA anatomy and FFRCT without any visual information provided by conventional coronary angiography in patient referred for CABG, complicated patient for CABG, is feasible and deemed safe in a select population with chronic coronary syndrome and low surgical risk. Not low surgical risk for other reasons, not for the complexity of the coronary artery. Of course, there were no concomitant surgery, et cetera, et cetera. And efficacy and has to be, safety has to be confirmed, and that's planning the syntax form, which is in good negotiation with the FDA and will be in Europe and United States. We still have to raise funds, which is the most difficult thing when you want to do a trial. That was for today. Thank you.
So I hope that you all understand that you've just listened to the most important lecture of this year's ICC. For me, I consider it one of the most impactful lectures I've ever heard, and I've listened to a lot of lectures. We are blessed with 13 and a half minutes left before our session ends, and we have a panel from the Cleveland Clinic, from Cedars-Sinai, from Oxford, to lead a discussion with Professor Sirois, and we will take questions from the floor as well. I'm going to just start first by thanking you, Patrick, for not just your partnership, but for your willingness to come here and share your wisdom with this group of coronary surgeons. You've made contributions that are really, truly remarkable to our field. And I think most important among them is your example of a scientist heart team partner. And I've lived that on these calls, the Zooms, that I've had a chance to be with you on Fast Track, and of course prior to that in other endeavors, but this has been a remarkable experience for me. I'm going to ask a provocative question to lead off our panel discussion. The latest ACC-AHA guidelines downgraded the indication for calculating and reporting the syntax score from a Class 1 recommendation to a Class 2B recommendation. Your thoughts?
Yeah, I think that on one hand, I'm not happy with that. I think we spend so much time, when you get the vital status 10 years later of all your patients on both sides of the Atlantic, it has a value. I have been in writing session of guideline. It's something very peculiar, the one which is the most vocal sometimes is the winner, okay? I remember when I was in the guideline in 2011, I introduced the syntax score because I had the syntax study. Today, the guideline in Europe, I don't know in the United States, the rule is not to use expert because they consider that the expert is biased by his last endeavor, study, investigation. It's a nice idea, but I don't think it's the right concept. And I can see that today, it takes a long, long time to generate guideline, and the guideline is a topic of debate. And that was not like that 10 years ago. 10 years ago, the guidelines were respected because they were built up by people who knew what they were talking about.
Yeah, I was part of that 2011 guidelines committee. I remember your discussion of the syntax score, and it always made complete sense to us as surgeons that we should quantitate the complexity of coronary disease. But it really was the syntax trial and your thoughtful leadership of it that made very clear to everybody that the complexity of coronary disease has a greater impact on PCI than on CABG, while the comorbidities that a patient brings has a greater impact on CABG than on PCI. And that helps us clarify which patients should have which of these very valid treatment options. I'm not against PCI. My father in his late 80s had a life-saving PCI in an acute coronary syndrome. I'm a fan of PCI for the right patient.
I think I have to say Dr. Sarais has given us one of the best lectures you'll ever hear. I would also say, in my opinion, and I've debated him many times over the years, so I know Dr. Sarais quite well, I think he's the most influential cardiologist since Dr. Andreas Grunzig. I don't think anyone's done more in the field of interventional cardiology. The one other person whom I would mention as a side is Dr. S.J. Park in Korea for the work he's done on left main stem disease. So these two cardiologists, but I have to say between them both, Dr. Sarais, in my opinion, has contributed more. But in this term of trying to understand how we interact with patients and having patient representatives, one of the things I've noticed is when I get on a British Airways flight and I knock on the cockpit door of the pilot to say, right, I want to see the route map and I want to discuss it with you, I'm not allowed to. So why do I have no say in my flight path to America, but yet we keep saying that patients... Now, every time we talk about patient consent and informed consent, that consent is only valid if the information given to the patient was valid. If you've given the patient the wrong information, they cannot consent to anything.
So let me say something about Fred. I mean, after all, we are here to celebrate. So when I went to see Fred, I knew him, I said we are going to booby trap him. And what we did, we used not your paper, but the paper just done before by Hoffman, yes, showing that in this trial there is 2%, 5%, that's it, something like that. And we present that slide, and I start a little bit in that style, hoping that he would say, no, I don't want to do this trial, I want to have an all-comers trial. And I give to John the slide, yes, where with his fits, he said, I'm not going to be part of that trial. And I said to Maria-Angèle, my partner in crime, I said, we have it. Now we have all-comers. Now, having said that, you must realize that there was more than 1,000 patients that the interventional cardiologist at that time said, I cannot do that. That's too complicated.
Yes.
1,000.
Yeah.
That's point number one. Then there were the 1,800 randomized. But in these 1,800 randomized, 2/3 were not doing well. So finally, you have on 2,800 patients, and it was a little bit more, only a small percentage. That's my percentage of 17% at 10 years. Mm-hmm. At 10 years, I can show that only PCI did well in 17%. But as I said, I have difficulty to publish that paper because it's obviously controversial, yeah, but I think it's true. The other thing that I would like to say is that we, surgeon and interventional cardiologists, we are not treating our patient properly. That's really amazing. In the syntax study, there were patients with and without statin. It's almost
yes,
Bayesian randomization. The mortality of the patient without statin was 36% at 10 years, versus 16 with
Yes,
the patient.
yeah.
In surgery, in mixed group. So we have to do something on the treatment.
Yeah.
And you know, you are in an era where you start to have now silencing for the LPA, silencing for the cholesterol, for the PCSK9, for the interleukin. It's amazing. I mean, at the American Heart, you have the first 10 patients treated with gene editing, one injection for the rest of your life, and your cholesterol is 50 milligrams. That's going to change because obviously we are a little bit diplodocus, if you see what is happening in terms of imaging, in terms of machine learning, and in terms of biology, I'm not so sure that will be the same in 2030, 7 years from now. Because that's a disease which is treatable. And if you go back to 1947, I was born in that year, the streptomycin and the penicillin has basically eradicated the infectious disease. Of course, we misuse it, etc., but that was a change.
Yeah.
That was a change. The streptomycin at the end of the war has really saved a lot of people. So are we going to see an era post-atherosclerosis at some point? Yeah. I think it's going to be faster than we believe.
Patrick, you make the point, and thank you very much for your contributions, and today's lecture was outstanding as a clinical cardiologist. The idea is that we need to treat earlier. That's the key. And we wait until people have disease. Absolutely. And then in clinical trials, as you and I have designed, we study the highest risk people because we have to have events. And yet we leave in the pyramid, we leave the bottom of the pyramid. So your thoughts about this, for this technology, should people have a CT angio at 40 years of age?
Yeah, I mean,
part of your...
Very good point. I mean, you have in New York Valentin Förster. Valentin is only interested in the people below 45. After that, he has no interest for the patient.
I was one of his fellows.
So I think it's true. We are going to come in Rotterdam, for instance. You can have your genomic for €1,000 now.
Yes.
I don't know what you're going to do with that, but at least you can have it. So I think that early detection in omics around the 20 years. In the United States, you can drive a car at 16, you can drink alcohol at 18 or 21, but you should make obligatory to have a genomic at 22,
Absolutely.
and then see what potentially is going to develop and then prevent. Prevent.
Beautiful.
The great things of the COVID is the microRNA.
Right.
You have billions of people who have received that, and it's not a catastrophe. Now we can use in medicine. That's what's going to happen, I think.
But leaving aside medical therapy, which we all agree is the most important thing to do, and my own group have published showing that in all the randomized trials, CABG patients got substantially inferior medical therapy. But the only intervention outside medical therapy we know that makes a difference to patients is having a patent IMA on your LAD. And the Cleveland Clinic have shown that if you've got a patent IMA on your LAD, there's no other intervention you can do to change survival. So I still think there's a real role to think about, and particularly 5 years ago in my center, if a patient was 52, they would be automatically stented. Now we offer, so we have a very rigid protocol for any intervention has to be agreed by a heart team. And I showed you the figures. On the difference in PCI versus CABG in different countries. So in my country, we have a pretty rigid protocol throughout the UK that any intervention, so the only time a cardiologist can intervene on a patient in the chronic situation is if the patient has 1 or 2 vessel disease not involving the LAD, and the patient must be documented to be on optimal medical therapy. And I think those are pretty good protection rules for most patients. But we now, compared to 5 years ago, even in younger patients who would previously have been automatically stented, if they've got proximal LAD disease, they're all offered the option of an internal mammary artery. I think it's great medicine. I think it's the way it should be. If the patient doesn't want it, fine, but at least they were given the proper options, because the only intervention that you can make in terms of coronary revascularization. So PCI in the stable situation has absolutely no effect on outcome compared to optimal medical therapy. But an IMA to your LAD definitely does.
You know, got the point, but there is a question there.
Well, there is a question, but the truth has to be said. You are one of a kind. We need to clone you. This is an echo chamber. We're cardiac surgeons, and we keep saying that CABG is better. The data supports that. The problem is the data gets picked up selectively, the patients get picked up selectively, the analysis gets done selectively to provide a different picture to the patient.
I think
And I would like to congratulate you on being such an impeccable scientist with integrity.
Yeah, it's not so difficult.
He used to say,
But I think what can become a major factor, why the interventional cardiologist has like a velociraptor, you know, went in and get the patient. Because the first things we were doing is puncturing the groin or puncturing the wrist. You create an emotional contact. And when you have seen the disease in a few minutes, you are the first person who said, gentlemen, you have narrowing here and there. I think I can fix it.
yes.
So you have to change that.
Yes.
How can you change that? You can change that by working with the radiologist
Yes.
or with the radiologist.
Yes.
The entry in the system has to become different.
But Patrick, the answer to it is dead simple. It's dead simple. No intervention should be done unless it's agreed by a heart team. Any individual doctor can convince a patient of anything. You say to them, walk up to floor 6 and
Yeah,
jump
but
off
you
a
don't
building.
listen to me. You don't listen to me. No, you don't listen to me. What I'm telling you, is that who is going to have the image of the coronary the first? That's the point.
Yes.
And I prefer the image that
Then you have
Patrick
really a heart team.
Yes.
Because the heart teams start outside the cath lab in the first place. That's what you have to do.
And the
it can
radiologist
happen.
is part of the team.
Yeah,
That's the
and it can happen.
Yeah.
And it can happen. Because what we have done in the fast track with John and the other surgeon and the radiologist, everybody was looking at the pictures. Everybody was aware of the complexity of the disease, and it was in a natural way than when you have make some calculation called machine learning and you see such a difference in mortality. There was no discussion, period.
Yeah.
You know, Patrick,
And I would-
you said, can I just make one point? Very important what Patrick said about the emotional tie to the patient. And this comes from benevolence. It doesn't come from malfeasance. So,
I agree.
you know, we need to acknowledge that. But the one person on the heart team, if we include the radiologist, does not have the emotional, is the radiologist. They're sitting in some place somewhere, and they have the objectivity.
Absolutely.
Have to be part of the heart
Absolutely.
team. Convinced
So
them.
And by the way, you don't need at a certain moment the radiologist. The pictures that you've
Yeah.
seen,
Yeah.
the layman can make the
Even
interpretation
yeah,
of
it
that.
could-
When I show the color code to the patient understands, you know.
Yeah.
I don't need a protocol in a written
Yes.
protocol. I
That's
need the
right.
pictures.
Patrick, we've run out of time, but I want to ask you to.
Well, the
Make
poor
some
man
predictions.
there, I mean,
got
not
one
poor.
question.
I mean,
Dr. Royce.
I feel responsible. Ask your question.
Thank you. Alistair Royce from Melbourne. And I agree with the others, a most fantastic talk. I'm about to start a study next week where the CT is the primary measurement for the study. How do we get our hands on your ultra-sophisticated imaging processing, and how do you get those goggles? Thanks so much.
The goggles is not so special, you know. It's my grandson is playing with the goggles all the time, and he's building during the night 3D printing. He does everything. Of course, he's more using Star Wars than anything else, but he's creating all these things. So the technology should not limit ourselves. I'm an old guy, but I like the new technology, and as long as you do that, you progress. Don't be afraid of machine learning. Don't be afraid of anything. It's like everything, you can understand that. So what was exactly your question then?
Can you have
You're afraid that you cannot get access to that?
Analysis, the sophisticated analysis of those CT images is way better than what I've seen in my own institution. So what are you doing that's so much better than what we're doing, and how can we get our hands on it by collaborating?
Yeah, you know, what you have seen at the end of my presentation is slice of 0.2 millimeter, okay? What you see sometime in your institution is slice of 7.5. The blooming effect of the calcium is terrible. I mean, that creates artificial stenosis. Then you don't rely on, when you will be trapped one time by I saw stenosis on the multi-slice CT scan, and it's not there on angio. It's most of the time an artifact, a mistake. But that quality of image, which is already available in 100 hospitals in the world, that's going to come strongly. This is no conflict of interest. This is Siemens, but you will have GE. GE will be there next year, third quarter of the year, FDA approved, et cetera, et cetera. So I think that quality of pictures, because it's an invention, like the MRI was an invention by the British a long time ago, when the invention is there and you start to use, you have a different perspective on what you do.
So, Patrick, it's GE that makes this photon counting CT scanner?
The Siemens is the one who has implemented 100, but GE is coming. The Karolinska Institute has already the GE photon counting.
Is one better than the other?
I would not say that.
If we're going to, so I mean, this is the last comment. We'll leave it to you to make. Walk us through the changes that are going to happen with the technology and the heart team in the next 36 months, 3 years.
Yesterday in Los Angeles, I was listening to Eric Topol and artificial intelligence. I'm reading these things, I'm reading this book. But again, what he has shown is unbelievable. You know, to use the retina to make 7, 8, 9 diagnosed just by looking your retina, because the machine learning has learned to identify a Parkinson, a diabetic, and so that's the world we are entering in. So everything is going to become, I think, much more easy. I think we will have more time for the patient. I read in the book of Eric Topol that on 12 minutes, the American physician is spending 10 typing and 2 minutes with high-to-high with the patient.
That's probably right.
That's what we have to change. We have to. I went through remote control AI anamnesis for angina. Unbelievable.
I have to say,
It's built up like a pyramid. Everything is there. How many times we ask to a patient, do you have wrist pain, only wrist pain during exercise? That's a sign of the incidence is pretty low, but we never ask that question. So the machine learning is doing that much better. You don't have to hide something, you just dictate, and it's typed, written, and organized.
Yeah.
So I think life is going to be more easier. We will have, again, more time for empathy with the patient.
Yeah, that's a great point.
if I can make one very final last comment from my perspective, I'm very skeptical about all of this. We've known for 10 years what the best treatment for patients with multivessel coronary artery disease, and I showed you the ratios of PCI to CABG around the world. For 10 years, we've got incontrovertible evidence what is best for patients. So the big question is, why are we not following the evidence? Thank you.
Okay, with that, I want to again thank Professor Sirois for giving us our keynote lecture.